Assalamu alaikum viewers. Our today's topic is pulmonary edema, understanding and diagnosing imaging manifestation, and how to diagnose on a chest x-ray, what are the findings we will see in this lecture.
The term pulmonaryedema not only related to cardiac condition, but actually divided into cardiogenic pulmonaryedema and non-cardiogenic pulmonaryedema. Cardiogenic pulmonaryedema result from condition affecting the heart, which leads to congestive heart failure and pulmonary edema with elevated pulmonary capillary wedge pressure, while non-cardiogenic pulmonaryedema result from systemic condition and lung condition severe enough to cause acute lung injury, result in acute respiratory distress syndrome, leads to non-cardiogenic pulmonary edema. Pulmonary capillary wedge pressure routinely not performed, but theoretically as an exam question, if patient with symptoms of pulmonary edema and with elevated pulmonary capillary wedge pressure more than 18, then you should diagnose as pulmonary edema related to heart or cardiogenic pulmonary edema. While if the pulmonary capillary wedge pressure below 18, it is non-cardiogenic pulmonary edema. And in this video, we will discuss about the cardiogenic pulmonary edema image manifestation and some non-cardiogenic pulmonary edema.
Pulmonary edema is one of the most commonest emergency condition presenting in almost every emergency department. So identifying the underlying etiology of the condition is very crucial to the appropriate therapy for the patient. Physiologically and pathologically divided into three types: cardiogenic pulmonary edema or volume overload pulmonary edema, resulting from rapid elevation in hydrostatic pressure in pulmonary capillaries, mostly due to hydrostatic pressure, while non-cardiogenic pulmonary edema resulting from increased capillary permeability, called as permeability edema. And third type is mixed hydrostatic and permeability edema, which is combine of both condition. We will go to the chest x-rays of pulmonary edema. We have to discuss some important terms related to image manifestation of pulmonary edema. So each alveolus is accompanied by capillary networks. Between the capillaries and alveolus, there is a space called interstitium. Physiological determinants of edema include hydrostatic pressure within the capillaries driving fluid out of the vessel, while oncotic pressure related to macromolecule protein in the blood help fluid retain in the vessel. The relative balance of hydrostatic pressure and oncotic pressure, in addition to the membrane permeability, determine the net fluid movements between the vascular and interstitium. Also, we will see here the lymphatic flow. Lymphatic channels also important in maintaining fluid balance, as they allow return of extravascular fluid back to the main vasculature. This is another diagram showing microvascular fluid exchange under normal physiological condition in the lung interstitium. This is the capillary vessel, and this is the alveolus, and this is the interstitium. The hydrostatic pressure forces try to move the fluid out, while the oncotic pressure keep the fluid in. Fluid and small protein leakage through the small gaps between capillary endothelial cells in the interstitial space do not enter the alveoli because of epithelial tight junction, and lymphatics remove most of the filter fluid from the interstitium at a rate of approximately 10 to 20 ml per hour. This is under normal physiological condition. In this diagram, we can see the pathophysiology of both cardiogenic pulmonary edema and non-cardiogenic pulmonary edema, also called as a hydrostatic pressure edema and permeability edema. The third type is combination of both hydrostatic pressure and permeability. The hydrostatic pressure edema, the two most common causes are volume overload and left ventricular failure. Once left ventricular failure started due to any disease, it will transmit back pressure of fluid blood to the left atrium. From the left atrium, pressure back to the pulmonary veins. From the pulmonary veins, it will be transmitted to small veins and capillaries. So there are three stages of pulmonary edema, hydrostatic pressure edema. Stage 1, as the pressure increases, the capillary try to accommodate the pressure and become dilated. In this stage, there is no problem in gas exchange. The still fluid try to crosses the barrier, but in stage 1, fluid will not crosses the barrier. As the pressure continue to increase in stage 2, the fluid ultimately crosses the endothelial barrier and accumulate in the interstitium. In the interstitium, the efficient lymphatics try to remove this extracellular fluid, but because of the continuous back pressure and hydrostatic pressure increase, fluid increases in the interstitium and overpower the lymphatics and unable to remove excess fluid. At this stage, there is a gas exchange problem and mild hypoxemia can happen. And in stage 3, the fluid ultimately crosses the alveolar epithelial barrier and alveola become flooded with the protein poor fluid, and at this stage the airways compromise and with severe gas exchange problem and severe hypoxemia, symptoms of frank pulmonary edema. So these are the stage 3. And by contrast, here in non-cardiogenic pulmonary edema, the permeability of the membrane increases and protein-rich fluid will enter in the alveoli. There are two types also of permeability edema. Permeability edema with diffuse alveolar damage. That means due to any injury to the epithelium, inflammatory cell injured the epithelium and try to all the fluid will accumulate in the alveoli due to the acute lung injury. So the protein also extravasate due to the epithelial barrier destruction, and so this is the protein rich fluid accumulate in the alveolus and severe gas exchange problem and patient present with the ARDS. And the second type, permeable edema without diffuse alveolar damage, when there are some changes in the membrane permeability without severe damage. So there is no severe damage in the membrane permeability, but there is some changes. So there is still fluid extravasate from the interstitium into the alveolus, and the example of this type of permeable edema without diffuse alveolar damage in cases of high altitude pulmonary edema or in cases of cytokine administration patient like interleukin 2 and opioid overdoses cases. In both the diffuse alveolar damage or without diffuse alveolar damage, the hydrostatic pressure will remain normal. The third type, the combination of hydrostatic pressure increase and permeability, membrane permeability increase. In the example of these cases are in cases of severe neurological injury and re-expansion pulmonary. Both we will discuss later in the video. So this is the pathophysiology of cardiogenic and non-cardiogenic pulmonary edema. Chest X-ray, there is a grading of pulmonary edema. In grade 0, the normal chest radiograph with pulmonary capillary wedge pressure is normal also 8 to 12 millimeter of mercury. In grade 1, shows evidence of upper lobe diversion on a chest radiograph, and pulmonary capillary wedge pressure will be between 13 to 18 millimeter of mercury. With grade 2 shows interstitial edema on chest radiograph, and pulmonary capillary wedge pressure at this stage is between 19 and 25 millimeter mercury. And grade 3 shows alveolar edema, alveolar flooding on chest radiograph, and pulmonary capillary wedge pressure is more than 25 millimeter of mercury. As we discussed in the previous slide about the interstitial edema and stage 1 of the pulmonary edema, stage 2 and stage 3 of the pulmonary edema. These on chest X-ray according to the pulmonary capillary wedge pressure and different stages, different grading in the chest X-ray. We will see in the next slide about how these grade can be seen on the chest X-ray. So these are the features of cardiogenic pulmonary edema on a chest X-ray. In the last slide, we discussed the grades of pulmonary edema, and in grade 1, the cephalization or upper lobe diversion, while grade 2 interstitial edema consists of features of peribronchial cuffing and curly lines. We will discuss in the chest X-ray in next slides, while grade 3 batwing appearance and air bronchogram in alveolar edema when the pulmonary capillary wedge pressure more than 25, the alveolar flooding or alveolar edema, and the features are batwing appearance with air bronchogram can be seen in that case with the batwing appearance. We will discuss these all features in the next slide on chest X-ray. So first feature in cases of cardiogenic pulmonary edema is the cephalization and or upper lobe diversion. Normally, because of the gravity, there is a less blood flow in the upper lobe, in upper zones, and the pulmonary vessels are small in caliber as compared to the lower zone. So the pulmonary vessels here are gravity dependent and they are more larger in caliber in comparison to the upper zones. Here you can see more closely that lower lobe vessels are looks like congested more in comparison to the upper zones, and you cannot track easily their borders. There are multiple vessels, you cannot track their border. But in the upper lobe, very few delicate small vessels, and you can track their borders easily. So these are the normally placed in comparison to the lower zones. Lower zone, more congested vessels, more gravity dependent, more blood flow, so they are visible easily, but you cannot trace their lines or borders. While here it is delicate small vessels, you can see only few vessels. Once there is a congested veins in upper lobe diversion, you will see more same like a lower zone vessels in upper zone. As we discussed before in pathophysiology of pulmonary edema, that once left atrial pressure increase and back pressure in the pulmonary veins, then in pulmonary, small pulmonary vessels and capillaries, they become dilate and try to accommodate the increased hydrostatic pressure. So here, this is the normal bronchus and this is the normal caliber vessel and this is the in between interstitial space. Once left atrial pressure increase, usually it is more than 10 to 15 millimeter of mercury. It transmits back pressure to the small vessels in the lungs and they become dilate, try to accommodate that hydrostatic pressure. And this dilated vessel can be seen in the X-ray as a upper lobe diversion or cephalization. Here you can see these previous X-ray normal, that one you did not see the vessels physiologically normally, but here because of upper lobe cephalization and upper lobe diversion due to left atrial pressure increase and the vessel dilate, and you can appreciate that there are multiple vessels can be seen here and their diameter is increased. And here you can see more clearly, this is the normal and in comparison this is the upper lobe diversion. So here lower lobe vessels, lower zone vessels, and here upper zone vessels are also dilate. So this is the stage 1 of pulmonary edema, when the pulmonary capillary wedge pressure is around 12 to 18 and still there is a no fluid in the interstitial space, only vessel dilate, try to accommodate the hydrostatic pressure, they are becoming large. And now you can see the multiple vessels, but diameter is increased, but you cannot track their borders easily. They are thick walled and multiple congested like. So this is the stage 1 of pulmonary edema, upper lobe diversion and cephalization. So as the hydrostatic pressure increase and fluid will extravasate from the capillary endothelium into the interstitial space and accumulate around the bronchi and bronchial wall become thick. So the second stage of pulmonary edema started, that is interstitial edema. Normally bronchi are not visible on X-ray because they are air containing, so they are radiolucent, so you cannot see normally bronchi on the chest X-ray because the rays pass easily through the air containing lungs, and so they are not visible. Only the other structure, dense structure, light fluid in the vessels and soft tissue, they appear gray and whitish. So once this is the normal bronchi, thin wall, once the fluid in the interstitial space accumulate around the bronchi, the bronchial wall become thick. Once the bronchial wall thick and it contain fluid, it will be visible on a chest X-ray as a peribronchial cuffing. So here you can see every bronchus is accompanied by vessels. So only vessels as a dot is available. A whitish dot or grayish dot is you can see on the most of the time on the chest X-rays. Bronchi are not visible. Once they become thick wall, in cases of peribronchial cuffing, you can see them easily. So this is the second stage as a peribronchial cuffing. And here you can see this is the bronchi are visible with their vessels. It is called as a peribronchial cuffing, thick wall bronchi. And in cases of stage 2 pulmonary edema, they are multiple and difficult to see actually because upper lobe diversion, cephalization with thickening of the septa and these some peribronchial cuffing, difficult to see, but if you concentrate can be seen as in mid of the hilar region and upper lobe region you can see these thick bronchi as peribronchial cuffing. Feature of the interstitial edema are curly lines or septal line. They represented the channels between peripheral and central lymphatics They run in the septas between the lobules, and there are multiple lines: curly A line, B line, C line, and D lines. So importance are mostly curly B lines. This is curly A line and this is C lines. They are centrally placed and horizontal, and usually difficult to see during cases of interstitial edema. Only mostly B lines are easily seen in the periphery. Curly B lines are at the periphery of the lung near the pleural surface. They are horizontal 1 to 2 centimeter, and mostly they are the one seen easily in cases of interstitial edema. Here you can see, and these are straight line, horizontal at the periphery, thin only. Their thickness is only 1 millimeter and 1 to 2 centimeter in length. Here close look, and here it is placed both multiple straight lines. So these are represent the second part of the interstitial, second feature of the interstitial edema. This X-ray shows increasing features of pulmonary edema. Here stage 1 of peribronchial vascularization, upper lobe diversion, and then peribronchial cuffing. Then these are the curly lines, and this is the fissure between the two lobes, upper and lower lobe. There is a fissure which is thickened and contain the fluid. Then this is the increasing interstitial edema, increasing hydrostatic pressure, ultimately break the barrier of the alveolar epithelial surface and enter the alveolar space, become alveoli become flooded with the fluid, and frank pulmonary edema will be started. Like this one, increase interstitial edema and increase hydrostatic pressure, fluid reach to the alveoli, and that will be seen as a fluffy opacities. So they are bilateral fluffy opacities, perihilar and lower zones. They are smooth like a cotton ball. They are not discrete, smooth cotton, and you can see bilateral. So the feature differentiate from the ARDS. They are bilaterally symmetrical and smooth, not nodular, fluffy. This is the feature. So this is also called as a bat wing. Bat wing appearance resembling to the bat and the wings of the bat. Mostly seen in cardiogenic pulmonary edema, but can be seen in pneumonias, inhalation injury, pulmonary hemorrhage, and other cases. This is more close look. You can see the surfaces are very smooth, bilateral, almost symmetrical, with cardiomegaly. And here another picture showing bilateral, haziness, fluffy. This is the normal lung, and here alveoli is flooded with the fluid. This is the frank pulmonary edema. This is another example. This is the bat, and bat wings resembling, not, some authors did not actually agree this is a bat wing, but can resembling a bat wing appearance. The last feature here of the pulmonary edema is air bronchogram. Usually air bronchogram are seen in non-cardiogenic pulmonary edema, but in some cases of severe pulmonary edema, when alveoli are flooded with the fluid, that time air bronchogram can be seen. So what is the air bronchogram? Usually the bronchi, small bronchi and bronchioles are not visible in the chest X-ray because they are radiolucent, containing air, so rays easily pass through them, and only air is black, radiolucent, so they cannot be seen. Once in the lung at the alveolar level, these fluid which is radiodense accumulate, like in consolidation in pulmonary edema. Around the alveoli fluid accumulate, it is radiodense, so it is whitish or grayish opacity can be seen in the area of the lung. So in the bronchi can be seen around that or in that opacity. This is the whitish radiodense opacity, and sometime bronchi can be seen. They are still air filled. So some of the bronchi can be seen in the middle or any site of the opacity, that is known as a air bronchogram. We can see the closely here. So you can see here, you can trace here the bronchus, which is around that radiodense opacity, whitish or grayish opacity, still bronchi. This is all fluid and consolidation around the bronchi, but still in between there is some air containing opacity, air containing alveoli can be seen, that is known as the air. You can see here, this is air bronchogram. So in that opacity, air filled bronchi can be seen as air bronchogram. Most common with the cases of non-cardiogenic pulmonary edema. So here is the difference between cardiogenic pulmonary edema and non-cardiogenic pulmonary edema. Obviously, cardiogenic pulmonary edema, cardiac cell will enlarge, while in non-cardiogenic it is normal. And regional distribution opacities are relative homogeneous. As we discussed before, homogeneous opacities, symmetrical. But here in the ARDS, they are patchy. We will see some X-ray of ARDS in the later slide. Air bronchogram are uncommon, and air bronchogram common in non-cardiogenic pulmonary edema, peribronchial cuffing in the cardiogenic pulmonary edema, and uncommon but can be seen sometime. And septal lines are more common with the cardiogenic pulmonary edema. So these are the most common differences between the cardiogenic and non-cardiogenic pulmonary edema. We will see some slides, some X-rays of the cardiogenic pulmonary edema and non-cardiogenic pulmonary edema. So you can see here, this is as we seen before the X-ray. Cardiogenic pulmonary edema are smooth, symmetrical opacities, fluffy, cotton ball, cotton-like, and in the cases of non-cardiogenic pulmonary edema, acute lung injury, ARDS, permeability edema, you can see the opacities all around the upper, lower, and middle zone, and some patchy opacities. There is some patchy opacities, discrete and patchy. They are not very well symmetrical in contrast to here. This is another X-ray. So here cardiomegaly obviously, and this is the bilateral smooth opacity, fluffy appearance, cardiogenic pulmonary edema, while here you can see cardiac size is normal. This is the main difference usually, and some patchy areas of opacity and some air bronchograms can be seen. So this is the non-cardiogenic pulmonary edema, or really ARDS. So here we will discuss one of the form of non-cardiogenic pulmonary edema, that is neurogenic pulmonary edema. So any devastating CNS injury in cases of status epilepticus, subarachnoid hemorrhage, subdural or intracranial hemorrhage, this patient can suffer neurogenic pulmonary edema. So what is the mechanism of this pulmonary edema? It is a mixed type of pulmonary edema involving both hydrostatic and permeability component. We discussed before cardiogenic pulmonary edema, which is hydrostatic pressure edema, and ARDS, which is permeability edema. Now this type has both component, hydrostatic and capillary permeability. So what happened? Transient sympathetic discharge in cases of neurological injury. The patient with these neurological condition, they have transient sympathetic discharge which cause pulmonary vasoconstriction, and pulmonary vasoconstriction lead to shear stress injury to the capillary membrane. Once capillary membrane is injured, the fluid extravasates into the interstitium, then to the alveoli, and can cause pulmonary edema, this form of non-cardiogenic pulmonary edema. Here we can see this is the X-ray of a patient with CNS injury, and here you can see bilateral haziness, fluffy appearance like a fluid bilaterally. So it was multiple time in these patients. After seeing that X-ray, it was think that this may be a cardiogenic pulmonary edema or a case of ARDS, but actually it is not cardiogenic pulmonary edema or not ARDS. It can happen in neurological pulmonary edema form of permeability and hydrostatic pressure edema. Though history is here very important. If the patient is non-cardiac, then plus patient also have features, no features of sepsis, and you see the picture in that X-ray, then you can label him as a neurogenic pulmonary edema. So here we will also discuss another form of non-cardiogenic pulmonary edema, asymmetric or unilateral pulmonary edema due to rapid re-expansion of a collapsed lung, and patient can develop acute dyspnea. Usually it occurs following 1% of pneumothorax and pleural fluid aspiration procedure, and unfortunately mortality can reach up to 20%. So the patient with pneumothorax and pleural effusion, mesopleural effusion, both pneumothorax and mesopleural effusion will cause the lung, adjacent lung will be collapsed due to pressure of the pneumothorax and pleural fluid. So once we aspirate the fluid rapidly, this collapsed lung will reopen or re-expand and can cause as acute dyspnea and asymmetric or unilateral pulmonary edema. What is the mechanism? This is the form of permeability edema and hydrostatic pressure edema related to endothelial changes occurring when the lung has been collapsed for 3 or more days. So the patient with the pleural effusion or pneumothorax with lung collapse 3 or more days to develop incidence of this type of pulmonary edema. So here this is the mechanism. Collapsed lung, typically more than 3 days to 7 days, pulmonary re-expansion will happen, evacuation of the pneumothorax, aspiration of the fluid. Once fluid will aspirate, what happen? That region will be rapid re-establishment of blood flow, because lung was collapsed due to pressure, so the blood flow at that site was decreased. Once the lung will re-expand, the blood flow in that area will start it with rapid alveolar expansion, and what happened? This cause increased pulmonary hydrostatic pressure. As the pulmonary blood flow will increase, it cause increased hydrostatic pressure, and this will cause re-expansion pulmonary edema. Second, the permeability component. So because of collapse, surfactant is decreased, regional tissue hypoxemia, alveoli will be collapse. And changes in alveolar capillary barrier, inflammatory cells migration, other inflammatory leukotrienes and other radicals on that site, injury to the capillary wall with increased capillary permeability. So once blood flow came, already migration of the polymorphonicular cells and interleukins and free radicals, capillary wall was injured, sudden increase in blood flow caused capillary damage, increased capillary permeability caused re-expansion, pulmonary edema. So both form the capillary permeability and other side is the hydrostatic pressure increase. Both in that area of the collapse will cause re-expansion pulmonaryedema. We will see the chest X-ray. So here, this is the chest X-ray. Here you can see this is the lung, this is the fluid. The fluid around the lung cause collapse of the adjacent lung. Once collapse for more than 3 to 7 days because of this fluid accumulation, so we started aspiration by the through needle. If we take out the whole fluid rapidly, this lung will expand, and once this lung expand, the blood flow, blood vessels also increase, become reopen, and the blood flow will increase, and the fluid extravasate from the into the interstitium and alveoli called pulmonary edema. So you see this is a unilateral. So this side, one side, because lung was the site where the pleural was aspirated. So this side is okay. You can see air black. Here it is a radiodense opacity. The fluid accumulate in that site immediately to re-expansion. So this is called unilateral or asymmetrical pulmonaryedema or re-expansion pulmonaryedema. We will see the another chest X-ray. This is the pneumothorax. You can see here this jet black, no vessels marking. Here you can see vessels marking, and here no vessel marking with the border of the lung and pleura here, collapsed lung here. So this is a huge, large pneumothorax causing tension pneumothorax as well. Once evacuated through by the chest tube inserted, and immediately the air pulled out of the pleural cavity into the drain, lung expand immediately, blood flow re-establish, and unilateral or asymmetrical pulmonary edema here. Here you can see another demonstration. So this is the aspiration, and chest tube was inserted. Once chest tube inserted, whole of the aspirated fluid, if evacuated at the same time, the re-expansion of pulmonary edema can happen. So what is the caution here? During aspiration, once you see the fluid is coming rapidly in the bottle, then you clamp the tube. After 500 or 700, 800 fluid aspirated, then you clamp the tube for some time and then reopen again intermittently to take all of the fluid intermittently, not at the once same time. This will be the prevention of the re-expansion pulmonary edema. So slowly withdrawn the aspirated fluid. So this is the re-expansion or asymmetrical pulmonary edema demonstration X-rays, and this is the chest tube demonstration, how to prevent the re-expansion. So in summary, pulmonary edema has a range of image manifestation that can be identified and diagnosed on chest X-ray with practice and experience. But underlying etiology of edema is crucial to diagnose for implication of appropriate treatment. In this lecture, you have learned types of edema, pathological mechanism, hydrostatic pressure edema, permeability edema, without diffuse liver damage, and mixed type of edema. Demonstrated common and uncommon radiographic manifestation of the edema. So in cases of severe pulmonary edema, that is alveolar edema, the fluid will accumulate in the alveoli and around the alveoli. It will decrease the airway diameter, compress the diameter of the airway, and patient appreciate the dyspnea and increase resistance to airflow as further increase in dyspnea. So you can hear expiratory wheeze. That is called as a cardiac asthma, but actually not asthma, that is heart failure, cardiogenic pulmonary edema. So all the wheezes are not asthma and can be diagnosed based on accurate history and clinical examination for appropriate treatment. So thank you very much